Good morning to everybody. Thank you, Saman, for your kind introduction. First of all, I would like to thank President and Secretary and Council members of the Kandy Society of Medicine for inviting me today for this clinical lecture. Why I'm reason to select this topic, menopause and HRT. This is the World Menopause Day, that is October 18. Again, in our region, South Asian Menopause Society subforms. There's an International Menopause Society as well. Not only that, Sri Lanka Menopause Society, and we have our own journal as well. That is menopause, and well recognize that importance of that. The one is lady, the woman is reaching to the menopause. Is not affecting the quality of life for her. That is affecting the whole the family. That they identify that and they are trying to improve the quality of the life. If you are they identify a lot of research in that area. There are a lot of publications and discussions and education programs. That's why then one reason to select this topic today. Then before starting this topic, I would like to highlight in some clinical case scenarios when we have to come across. One is a 42 years old mother of 3 children have underwent a TH and BSO reason for severe endometriosis. There's another lady, 38 years old Nalipara, present to the gynecology clinic with the menopausal symptoms. 2 serum FSH level were done and both were more than 40. There's another lady, 50 years old lady, known patient with the type 2 diabetic mellitus and chronic hypertension for last 5 years and present to the frequent night sweats, mood changes and hot flushes. Her blood pressure is 150/90 and fasting blood sugar is 100 mg per deciliter. There's another one is 48-year-old lady underwent a right side mastectomy due to the breast carcinoma 2 years ago. Now present to the gynecology clinic with the climacteric symptoms. There's another 50 years old lady with a history of menopause at the age of 40 and currently diagnosed with severe osteoporosis. These are main some area I try to catch in the what are the area we want to highlight. What is the meaning of menopause? Menopause comes from the Greek word menos, that is month. Posis is cessation. Month cessation is menopause. It's mostly we are based on the clinical diagnosis. That is diagnosis made retrospectively after minimum of 1 year of amenorrhea. Again, when we are discussing about menopause in the life expectancy, any female is better than male. That is now even 76, 78. That means 1/3 of their life they have to face with menopausal signs and symptoms. That is one reason is nowadays there are a lot of discussion about quality of life of female patients. We know at birth there are 1 to 2 million follicles in our ovaries. As a result of our destructions, there are a lot of various reactions is there. At the time of menarche, that is remaining is 500,000 follicles. Then each menstrual cycle, they are destroying significant number of follicles. The peak is destruction is starting at the age of 37 and 38. This is the reason actually if you are waiting for treating and identify menopausal symptoms at the age of 50 and 52, that is too late. That is we have to identify little bit early menopause, early perimenopausal age, or early 40s. Then identify the women who are high risk of early menopause and we have to start treatment and identify and education start. Again, main important factor to decide the age of menopause, the time of menopause, not really the age, the number of follicles. Number of follicles is less than 1,000. The ovaries are not respond to the hypopituitary thalamus of actions. Then as a result of that, FSH level is increased. When we are discussing about menopause, that is symptoms are important. Then menopausal symptoms, we can short term, intermediate and long term. The short term, the most of the patients are coming to us with the short term symptoms. These are short term, mainly physical and psychological. We can divide hot flushes, night sweats, palpitation, sexual changes. When we are moving to the psychological, depression, irritability, anxiety, because that is most of the ladies in the just early menopause, that is first 1 and 2 years, they can't tolerate. Again, intermediate, mainly urogenital and skin changes are there. Long term, that is the main one, is affecting the quality of life. If you identify, especially early menopause ladies, directly affecting their bone, brain and heart. This is how she is suffering with hot flushes and menopausal symptoms. It shows, you can just imagine that. This is one, again another some example of menopausal period that is they are suffering, that related with the menopausal sign and symptoms. How we are going to diagnose? As I mentioned, is mainly clinical diagnosis. Then without lab test, those who are ages more than 45, perimenopausal based vasomotor symptoms and irregular period is more than enough. Then menopausal based amenorrhea more than 12 months and are not using any hormonal contraception, then we can come to the diagnosis. There's another group, menopausal symptoms are there without a uterus. Then we can come to the clinical diagnosis. But in some group of patients, we can't 100% clinical diagnosis, especially those who are age of 40 to 45 with menopausal symptoms and irregular cycles. We have to do a biochemical laboratory test. When we are discussing about laboratory test, FSH is the most important one. Then when we are doing FSH, sometimes it's one reading is not enough. We have to do at least 2 readings 4 to 6 weeks apart. There's another group, that is ages less than 40. This is a premature menopause group. Then mainly diagnosis depend on the FSH level. But we are not using FSH level to diagnose the menopause. Those who are using combined oral and progesterone contraception or high dose of progesterone. Then before you are using that one, we have to get a better history. What are the management options? Lifestyle modification, HRT and alternatives and complementary therapies. Lifestyle modification must be the first. But now we are used to that most of the time. Problem is then we are trying to give HRT the first line. No. First, as I mentioned earlier, then if we can identify with a better history in our gynecology clinic or even your medical clinic, if you are going to identify the risks of the patients, then what are the lifestyle risk and their dietary habits and the other occupation level, how can they are high risk, identify and then better advice, and at least daily exercises and balanced diets is very, very important. After that, we can think about other medical treatment. What are the hormonal and drugs therapies for menopausal ladies? That is estrogen, progesterone, testosterone, raloxifene and testosterone. Then when we are discussing about short term, vasomotor symptoms are the most problematic one. That's the reason most of the ladies is coming to us. Then vasomotor symptoms is present in the first year with the 60-70% of ladies, but later in the latter part of the menopause period, especially 5 years, they are present only 30 to 25% of females. Vasomotor symptoms, when we are treating estrogen and progesterone to women with uterus, and estrogen alone we can use without uterus. Do not use selective serotonin reuptake inhibitors or clonidine as a first-line treatment for vasomotor symptoms. Some evidence say that they are then some effect of some other medical treatment, complementary therapies, but there are some not enough evidence. But most of the time, if patients are not suitable or HRT, then we have to move to the complementary therapies. Psychological symptoms. HRT or cognitive behavioral therapy can be used to treat low mood. There is no evidence that selective serotonin reuptake inhibitors improve the low mood in menopausal women who are not being diagnosed with depression. Altered sexual function. This testosterone supplement is a good option, especially these are not respond to the HRT for those who are during that menopausal period. Urogenital atrophy, other reasons they are coming that again directly affect to their quality of life, even sexual life as well. Vaginal estrogen, as long as needed, can be used even with systemic HRT are contraindicated. Routing endometrial thickening, one advantage of that one, routing endometrial thickening monitoring is not necessary. Vaginal estrogen therapies are freely available in our market. How we are going to review and follow up, especially after starting HRT, especially as I mentioned, vasomotor symptoms, urogenital symptoms, then first 3 months to assess efficacy and tolerability. Thereafter, then annually, unless there's no clinical indications. Then the starting and stopping the treatment, HRT, other important thing. Then after starting, doctor-patient relationship is very important. Most of the problem is that one, when you after starting, there's no good communication with your patients. Then one problem is the undiagnosed, unscheduled vaginal bleeding. That is, we can expect in the early first 3 months. But if the first vaginal bleeding is persisting after even starting treatment, we have to regular assessment is very important. One way of assessment is that we can do a transvaginal scan. Other one is sometimes hysteroscopy, even sometimes pupil aspiration. Then even patient is persistently more than 6 months, even after treatment, we can stop the treatment and we can reassess. Recurrence of the short-term symptoms may be less if gradually reducing the HRT. If we suddenly stop that HRT, sometimes they can't tolerate. Then if we need for short-term period, we can gradually reduce the amount of HRT. When we are discussing about long-term, especially those who have brain, bone and heart, then they need long-term treatment of HRT. Especially when we are thinking about long-term, one main problem is a venous thromboembolism. Oral HRT increases the venous thromboembolism risk. It is higher than the transdermal route. For women at high risk of venous thromboembolism and BMI is more than 30, transdermal is better than oral route. Women who has high risk of venous thromboembolism with a history refer to the hematologist to assess before starting the treatment. There are various studies related with the HRT. One, a popular WHI study that is mainly based about that one cardiovascular diseases. WHI study done in USA, that is study population was that one 50 to 79. Then they identify younger women, that is younger menopausal ladies 50 to 59 taking HRT over a period of 10 years have shown no increased risk of developing heart diseases. Again, in the WHI study, another arm showing that risk of cardiac disease, that problem is the elderly population that is away from the menopause, that is more towards the after 70s. There is another study that has shown women who are initiated hormonal therapy closer to the menopause tend to have a reduced cardiovascular disease risk compared to the increased cardiovascular risk among women is distant from the menopause. What is NICE guideline is mentioned about regarding cardiovascular disease and HRT. HRT does not increase the cardiovascular risk when started for who less than 60 age of years. Presence of cardiovascular risk factors is not a contraindication to HRT unless they are optimally managed. HRT with estrogen alone is no or less risk of coronary heart diseases. HRT with estrogen and progesterone still little or no increase the coronary heart diseases. There is a small increase in the risk of stroke in women who are taking oral estrogen. Type 2 diabetics. Again, other area we are thinking before starting HRT. According to the NICE guideline, taking HRT is not associated with increased risk of developing type 2 diabetics. Breast cancer, yes. We have to concern about breast cancer. That is the one problem is that one HRT, yes. Then breast cancer, there are a lot of studies again related with the breast cancer. Then one is the million women study that is done in UK, that is over million women. Then current use of HRT is associated with increased risk of incident and fatal breast cancer. They are substantially greater in the estrogen progesterone combination than the other type of HRT. There is wisdom study that's also they are done. So over 100,000 ladies in the USA, that is for risk of breast cancers. The main morbidity is recorded in the women. International study, long duration estrogen after menopause. Again, we have that I want to highlight here. If you still starting HRT, then we have to identify the duration, exact duration, and communicate with the patient, and close monitoring is important. According to the NICE guideline, that is latest 2019, HRT with estrogen no longer associated with the little or no changes in the risk of breast carcinoma. HRT with estrogen and progesterone can increase the risk of breast carcinoma. Increased risk of depending on the treatment duration and risk reduced after stopping of this HRT. Mammography. Then usually after starting the HRT, what is we have to advise? We are usually advised every 2 to 3 years is advised to do a mammography. But there are also some problem with the sensitivity. Mammography may not detect some breast cancers. Approximately 1/4 of the women taking combined estrogen and progesterone preparation will show significant increased mammographic density. As a result of that, then they are reduced the sensitivity of diagnosis of breast cancer. Then we are when patient on HRT, especially estrogen progesterone combination. The osteoporosis, that is the one important area I want to highlight. Those who are reaching to the menopause before the age of 50, natural menopause, or sometimes as a result of bilateral oophorectomy, or sometimes, as I mentioned, is they are reaching the naturally before the age of 40, that is premature menopausal age. The group is high risk of osteoporosis. We know in the female life, then after the menopause in their life, 1/3 of females, they are high risk of osteoporosis. Out of that high risk osteoporosis group, then 50% in their lifetime, they are risk of 50% of bone fractures. If you identify that group, especially those who are reaching to menopause before the age of 50, then there's a place for HRT. It's the first line management for osteoporosis. Then especially if we started HRT in the early part, that is around 50, we can continue some years, but regularly we need to assess that one. But then after around 55, really they are coming for osteoporosis features, osteoporosis fracture, there's a high risk group. Then other option is the SERM. I'll discuss that one is the value of SERM. Then those who are coming the little bit latter part, around 60, after 55, then there's no place for HRT, because those are a lot of vascular changes. Then HRT easily can cause of vascular stroke, vascular changes, this carcinoma. Then we have to bisphosphonate that type of medical treatment we can offer. Again, dementia. Likelihood of HRT affecting their disease dementia is unknown. There is loss of muscle mass and strength. There is a limited evidence suggesting that HRT may improve the muscle mass and their strength. Cognition and HRT. In women with menopausal symptoms, HRT may have specific cognitive effect, and future studies is necessary for further assessment. Then when you are thinking about the other cancer, breast cancer, I already discussed the WHI study. I mentioned that one. That is beginning, they have identified high risk, but according to the NICE guide is mentioned that one, that risk is less. Endometrial cancers, unopposed estrogen therapy should not be used women with intact uterus, because that increase of endometrial cancers. Ovarian cancers, according to the 1 million women study, they have identified there's a risk of ovarian cancer is 1 in 250. Bowel cancer, the small decrease in bowel cancer, 8 for 10,000 per year. Then simple way, what we discuss, then what are the benefits I would like to highlight. General, most effective therapy for vasomotor symptom and estrogen deficiency urogenital symptoms. Other menopausal related complaints such as joint, muscle pain, mood swing, and sleep disturbance, sexual dysfunction improve during HRT. These are all short-term complications. That is, if you are starting in the correct place, then we can improve their quality of life. Again, they are improve the quality life and sexuality as well. Then again, reduce postmenopausal osteoporosis. Then effective in preventing and bone loss associated with the menopausal and decreases in the incidence of osteoporosis related fractures. Especially for osteoporosis, those who are around 40 and less than 40, that is for therapeutic and prevention for osteoporosis, is a first line management. When we are discussing about cardiovascular diseases, HRT reduces the risk of diabetes and has positive effect on other risk factors for cardiovascular diseases such as lipid profile and metabolic syndromes. The other benefits, HRT has benefits of the cognitive tissues, connective tissues, skin, joint and intervertebral disc. Again, HRT reduces the risk of colonic cancers. Then what are the adverse effects? In the various way can affect that one. This is including the WHI study. I said the WHI study that study population of 50 to 79. The young menopause and all menopause all together. They identified strokes, high blood pressure, venous thromboembolism, breast cancers, and unopposed estrogen can cause endometrial hyperplasia and carcinoma. The main problem was the WHI study was selection of the patient. Current recommendations. The use of lowest dose for shorter period of time. Then we have to, as a doctor, we have to get the proper history from the patient, personal history and family history of breast cancers, stroke, cardiovascular diseases and osteoporosis. Then with that we have to identify their risk factors and we have to start duration and what are the ideal contraceptions, ideal HRT. Risks associated with the use of HRT are low. If necessary, we can extend it. That is, regular follow-up is important. At beginning, from every 3 months time, if we can't identify risk factors, then yearly we have to assess that. Starting HRT at early onset of the menopause and carrying up for few years apparently carry a little risk of healthy women. Tribalone, the other option, those who are high risk for HRT, or we can't, various reasons, we sometimes contraindicate as I mean venous thromboembolism, then we can, or breast cancers, risk of breast cancers, tribalone is a good option. So steroid with the estrogenic, progesterogenic and androgenic properties. Tribalone has a moderately effective action on the menopausal and urogenital symptoms, libido and bone. Then it protective for osteoporosis as well. Breast cancer risk is less than combined estrogen progesterone therapy. In that way, those who are high risk for breast cancer, and if we need to start for menopausal symptoms or urogenital symptoms, libido or osteoporosis, tribalone is a good option. SERM is, for example, we know that tamoxifen and raloxifene is usually commonly we are using that. Some are is a class of compound that affect the estrogen receptors. There are two types of receptors, alpha and beta. Their action is different in the various tissues, thereby selectively inhibit or stimulate the estrogen-like action on the various tissues. Tamoxifen and raloxifene are agonists at bone and antagonists at the breast. Hence, it's very helpful to use the osteoporosis and avoid the risk of breast cancers. That is the main advantage of SERM. But the disadvantage of SERM is not help to the hot flushes, climacteric symptoms. Sometimes when we are starting, those who are, if really necessary, if HRT contraindicate, then if you want to move to the SERM for osteoporosis, then avoid the hot flushes, we have to something other treatment options as well. And one other positive and advantage of the is some positive effect on the lipoprotein profile. Complementary therapies, that is freely available, but it's not very sure about that benefits. But those who are contraindicate for HRT, or even some patients are not happy to take at the beginning, first line, then we can think about complementary therapies. Efficacy and safety of the unregulated compound bioidentical hormones are unknown. It is still uncertain about the appropriate doses, persistence of effect, nature and potency of the various preparations and potential other drugs interactions. Before starting HRT, sometimes some situation we have to assess the FSH level, but not always. Mainly we are based on the clinical diagnosis. At least breast examination, pelvic examination in some group of patients, those are unusual vaginal or unidentified on and off vaginal bleeding or vaginal discharges. Again, we're better to measure blood pressure and fasting blood sugar, sometimes lipid profile, and what is the weight. Usually those who are more than 30 have some little bit risk for venous thromboembolism. During after starting HRT, need to regular follow-up, and regular pap smear may be important. Monthly breast self-examination we can advise. Mammogram after the age of 40. Again, after start, if you need to, we have to follow up. We have to continue for some period. Mammography every 2 to 3 years. Women taking HRT should have at least an annual consultation to include the physical examination, update the medical history, relevant laboratory and imaging investigations, and discussion on the lifestyle. Then when your patient is taken and follow up, then we have to ideally weight the medical history as well. Those who is not control their blood pressure and their blood sugar level, what we have to advise before starting, we have to refer to the physician and optimize their control. And after control, even diabetic hypertension or diagnosed lipid level is after control, there is no contraindicate to start. There is another group of patients, 5% of the women, that is premature ovarian failure. These are the high risk for long-term side effects, brain, bone and heart. Premature ovarian failure is diagnosed women is less than 40 years of age. Again, if you are clinically, the menopausal symptoms or no more frequent periods or elevated FSH level in 2 blood samples taken 4 to 6 weeks apart. Women with premature ovarian failure are at increased risk of developing osteoporosis and cardiovascular diseases. Sixth, management is again premature menopause is very important because, as I mentioned, they are the high risk of cardiovascular diseases, osteoporosis and climacteric symptoms. Sixth, steroid replacement, because they are directly affect the sexual life. Again, HRT is a good option, plus or minus testosterone. Again, combine estrogen, progesterone, contraception. Actually, what is available, even Mithuri is a good option for this type of group patient. Contraception, estrogen, progesterone combination is freely available. Most of the problem is when we are discussing about HRT, it's very cost effective, very expensive. Most of our patients we can't offer, they can't offer. Then that type of group, especially if you really necessary estrogen, progesterone, just Mithuri is okay till at the age of natural menopause. Then they are what is there naturally, they are in the amount is almost same as the normal way. Then no contraindication. There are a lot of studies, even nice guidelines mentioned about combined estrogen progesterone preparation, especially those who premature ovarian failure is we can use. It is contraindicated person, refer to the specialist and provide advice and cardiovascular health and symptomatic management. Again, I would like to move that again at the end. What are the clinical case scenario? I mentioned that. First one is 42 years women underwent a TH and BSO, severe endometriosis. Then after TH and BSO, 42, she's young, till 50. Again, as I mentioned, we can start estrogen and progesterone combination. Even Mithuri is all right till age of 50. If then something is coming from that, their income is less than 1,000. If you are asking for hormonal replacement therapy like other expensive one, they are never come to us and they are never going to treatment. Then we can start estrogen progesterone combinations. Again, then other one, 38-year-old lady Nalipera, that is premature menopause, identified premature menopause. She's with high risk. Again, for this lady also, lifestyle modification, balanced diet, exercises, and again combine estrogen progesterone combination. Contraception is okay for that because she's so young. There's no, but we know that there are some Mithuri, even Mithuri when we are discussing because commonly available, some estrogen progesterone combination, there are some group of patients is contraindicated. That is some liver diseases, venous, diagnose strong family history and personal family history of venous thromboembolism. I'm not discussing about that group, but those who are low risk for venous thromboembolism, some other cardiovascular diseases, estrogen, progesterone, contraceptions are okay. There's the third one, 50-year-old lady, person with a type 2 diabetic and chronic hypertension for 5 years. Her blood pressure is fairly okay, 150/90, and her fasting blood sugar is normal. She's indication if you have a climacteric symptom for short period, so we can offer HRT. That is because of quality of life. The other one, 50-year-old lady, underwent a mastectomy, diagnosed breast carcinoma, that is 2 years ago, coming with climacteric symptom. That type of patient we can't offer HRT. Then that type of patient, even the other option, the other option we have to discuss. We can, but first we have to counsel the patient. Then other complementary therapies we can offer. Then for short period we can start complementary therapies. Then other one is 60 years. That main problem is severe osteoporosis, but in the latter part of the menopause. Then there's no place for HRT. Then bisphosphonate may be a good option. We have to refer to the medical team and they have get their opinion. Then HRT not the HRT we can't offer that age of 60 for just treating for osteoporosis because they need for long-term medications. Then bisphosphonate is a good option. Thank you very much.